Hi, my name is Brittany Irick. I work at the Montague County Health Department, and I am the coordinator for the Montague County Quick Response Team. And I will ask Joe to quickly introduce himself as well.
So my name is Joe Class. I'm also with the Montague County Health Department, and I'm our assistant QRT coordinator.
All right, and so we're just going to talk to you all about what the QRT is and the work that we do here in Mon County. And so this is just a quick little snapshot of many of the partners that we have. But before we dive in, I'm just going to do a quick background of what is a QRT, if you're not familiar with that phrase. So a QRT is a community-focused initiative that's designed to combat addiction, particularly in response to the opioid epidemic. And so the first QRT originated in the Coleraine Township in Ohio in 2015. So this was a partnership between the Coleraine Fire Department, their police department, healthcare providers, and addiction recovery services. So this was really one of the first programs of its kind in the United States. Their mission was to provide timely, compassionate support to individuals struggling with SUD, especially those who have survived an overdose. And so this was at the height of the opioid epidemic, and they created this as a response to help people and get them into treatment and provide services to them. So a little bit more about what is a QRT. Let me move this, sorry. So a QRT is essentially just an interdisciplinary team comprised of various community stakeholders. And so for us, this looks like public health, social services, law enforcement, faith-based community, peer recovery coaches. We now refer to them as peer recovery support specialists. We also have pharmacy and then EMS, fire, 911, dispatch. And so the way the QRT works is the first responders share data. The data is related to substance misuse in the county or in the community, and the targeted group of individuals respond to substance-related referrals. And so that's the peer recovery support specialist, and they follow up with these individuals within 24 to 72 hours. And they offer individuals with SUD and co-occurring disorders, as well as their loved ones, access to services. And we'll talk a little bit more about what those specific services are. And so this is a quote from our previous health officer and executive director at the health department. And he used to say that if you've seen one QRT, you've seen one QRT. And essentially, what he means by that is every QRT is different. The composition of them varies by county to state, and so our QRT looks a lot different. The Coleraine Township, it also looks a lot different to QRTs throughout the state of West Virginia. And so the history of the Montague County QRT. We began our QRT in 2019 with the support of a $230,000 grant from the West Virginia DHHR through the Office of Maternal, Child, and Family Health. And so originally this was a post-overdose response team, but we've since expanded to focus on prevention as well. The the goal of the QRT whenever it began was also to focus on opioids because that was what we were seeing the most at that time. But we've shifted to a general SUD approach regardless of the substance, and we don't focus or respond to just opioids anymore. So, what are some of the goals of our QRT? Our main goal is to lower morbidity and mortality rates for individuals misusing substances. We want to increase access to Narcan and train laypersons in the community. We want to interface with individuals who have survived an overdose, increase access to community-based resources. We want to lower incidence and prevalence of communicable diseases associated with substance misuse. We want to improve SUD related outcomes and publish research and promising practices. And we'll go into some of these a little more. So how do we do what we do? We talked about it a little bit about receiving the reports and the PRSS is following up. But just to add a little bit more context, we specifically use a HIPAA compliant Dropbox where first responders and primarily most of our data comes from EMS reports and they go into the Dropbox and the PRSS's review this information every day, and then they go out into the community and follow up with these individuals. And so that's the primary component of our QRT. But in addition to that, we have bi-monthly meetings and we invite different stakeholders and all of our partners to join us for these meetings. And it's sort of an opportunity to discuss challenges, successes, what's going on in the community, trends that we're seeing, issues that people are working through. And it's really just an opportunity for anybody who's working in this field to come and get support or share ideas and feedback. In addition to that, um, the main goal of what the PRSSs do is to do weekly follow-ups with individuals who have experienced an overdose. Um, they link these individuals to services and treatment. And so another thing that we like to mention is that the goal isn't always to initially get them into treatment. It's just to establish a relationship with them, make sure that all of their basic needs are met, and then later on, if they decide that treatment's the right option for them, then at that point they've established a really good relationship with them and they can get them into treatment or whatever it is that they need. So I will hand it over to Joe and he will talk a little bit more about the peers work.
Yeah, and one of the unique things about the QRT model is, I mean, going through all the different things that can happen within the QRT. I mean, a lot of it isn't necessarily reinventing the wheel, but what makes the QRT unique, I think, is the fact that you have all these different organizations kind of basically coming under one roof or in one network. So regardless of whether an individual's touch point is with a peer recovery coach, with a first responder, maybe they're just out on the street and talk to one of someone who's on our QRT, is they can then link them potentially to all the other services. So I think that's really one of the key advantages of the QRT model. And then, looking at the peer recovery support services, the peer recovery support specialists are really the boots on the ground for our QRT and actually for a lot of QRTs because these are individuals who not only have lived experience and are in recovery now, but also they have received, hundreds, if not thousands of hours on counseling, mental health, motivational interviewing, just to, name a couple of the key trainings they have. So, when they go out and talk to an individual after an overdose or someone who's struggling with SUD, is, what they say has a lot more power than say, myself going out there and saying, oh, you should get into recovery, you shouldn't use substances, because these people have been through it. They are in recovery, so they can provide not only, the technical and textbook answers, but also lived experience. So, the peers can connect individuals with not only, SUD related information and resources, but also social services, healthcare connections, infectious disease management, behavioral health, employment services, legal help, and then this linkages to other support services. So, like Brittany said, not everyone is necessarily always ready to get into recovery. So maybe the first thing is simply, getting them an ID so they can potentially get other services or get housing. Maybe it's getting them some food and clothing or shelter. So the peer recovery support specialists really are a jack of all trades. And they are like I said before, they are the boots on the ground pushing, our services forward and trying to link everyone to the services that they need. So kind of some of the key, if you want to like boil down what our QRT does, some of the key areas, we have naloxone administration and or I guess naloxone training and naloxone distribution. So we give out a lot of Narcan, a lot of naloxone, so do the peers as well. And then we also do a lot of trainings on naloxone as well as CPR. because naloxone is one of the key, as I'm sure a lot of people here know, is really one of the key ways to keep someone alive if after they've suffered an opioid overdose. And you have to be alive to get into treatment and recovery. Patient advocacy is also, a critical part. So, the peers will help individuals um, get in to see primary care, get into any type of health clinic that they may need, social services. The end goal is, normally treatment. However, everyone's path is going to be a little bit different as far as how they get there. And that's once again where the peers kind of come and they can kind of, be the Sherpas for each patient and get them to where they need to go. And then, of course, harm reduction, which, harm reduction, the word comes and goes with favor right now. It's, kind of a dirty word, at least if you talk to some people. But, we still believe in the fact that, we want to make sure that people are healthy, are not spreading disease, and we are keeping people alive so they can get into recovery. So one of the things, since we've been around, our Montague County QRT has been around for a while, is, we have kind of grown to be able to offer a couple of different, specializations or services. We've actually had a couple of different smaller and larger grants where we have assisted other QRT teams in kind of establishing their quick response teams. So some of the areas that we've kind of I guess we've come to specialize in or are decent at is grant writing and management, project coordination, data analysis, curriculum creation, development, education and training, and then of course CPR and naloxone training. So, one of the big things that we try to do, within our health department and within our QRT is we want to make things that are reproducible in other areas. So, of course, every QRT or every intervention is going to be a little bit different, but we love to share kind of what we have learned and what we are, hopefully pretty good at, so we can help out other groups and organizations who may not have as many resources as we do. And then these are some of the actually could probably update the slide. We have a bunch of other stuff we can put here, but we do a lot of outreach, just providing information on not only what a QRT is, but also what substance use disorder is, and how it affects everyone. We used to have a grief support group. Currently, that is not operational, but we are hoping to get something like that back up and running. And we have in the past, and actually still do, work with the U.S. attorney on various things. They ask us, kind of what we're seeing in our county, in our region. We provide information to them. They kind of let us know what they're doing at the state and federal level. And one of the areas where the QRTs actually kind of started to get involved a little more is human trafficking. So, I mean, as I'm sure everyone is aware, human trafficking happens everywhere. In fact, I was actually at a conference last week where they did some case studies on human trafficking cases within West Virginia, fairly large cases. These were indicted federally. So it happens everywhere. So, and the peers interact with, hundreds and hundreds of individuals. Um, within a month, within a year. So, getting them trained on how to identify, human trafficking and what steps to take if they do think someone is being human trafficked, has been kind of one of the areas where they've been able to kind of help out in other facets that are not this SUD related. And like I said before, we've mentored other QRTs. So in this case, we went to, or the Kentucky QRT came here to kind of see how we did it. And then we've also traveled to other locations to see how other QRTs operate. And, similar to that quote at the beginning is every QRT has kind of some of the key, a lot of the key goals are the same, but how they accomplish it is always a little bit different, which makes sense because generally QRTs are going to be run through their county or through their region. So these are individuals that live in and around that county or region, so they're going to know their location best, and they're going to be able to kind of customize their specific interventions and how they operate to meet the needs of their communities. And now we're going to quickly just go over some of our data. So I'm going to preface this by saying that while technically, per the state system, I'm an epidemiologist. If you look at my job category, I'm not an epidemiologist. Not great at math. I love data. I think it's really important, but I'm better at using the data, not actually explaining or analyzing the data. So just a couple of things here for those of you that are really, that love epi or love biostats, don't hesitate to reach out to us and we can get you in contact with our epidemiologist and data improvement coordinator who loves this stuff and is the expert.
Yeah, and just to add to that, he was supposed to be here today to go over this, and he it actually had a previously scheduled vacation that he forgot about. So we're going to do the highlights of this. But yes, if you have specific questions, please feel free to let me know, and we can route you to Jacob.
So can you go to the next? Perfect. Yeah. So when we talk about, the data flow broadly, we receive data a lot of different ways, and that data goes to a lot of different locations. So I kind of like this slide. It's potentially a little bit hard to see, but basically, this is the flow of data within our QRT and also kind of explains where the data goes when it leaves our QRT. So when someone calls 911 for an overdose, right, that information from the 911 caller is going to go into a 911 CAD system, computer automated dispatch system. Um, and then once that happens, EMS is going to be dispatched. They're going to arrive on scene. And once they have treated the patient, potentially transported the patient to the hospital, they're then going to put, the information that they received on scene as well as their treatments into a patient care platform. And that data is going to go to basically a cloud-based system within that EMS charting software. And then that data is going to go to our state system. It's then going to go to a national system. Can you go back for a second, Brittany?
I'm trying. It's not working. I'm sorry.
That's okay. So that's one of the that's one of the things that makes it a little bit more complicated as far as, because we hear the question all the time of, so how many overdoses are you actually having, or are you seeing an increase or decrease? There's really no standardization. So being able to, every EMS crew is going to chart a little bit differently. While there are certain ways to kind of standardize it, as far as like kind of like a checkbox, like, naloxone was used or not used, it's very difficult to get an accurate number. And also, we're seeing a lot more that not everyone calls 911 with an overdose. And in fact, I think kind of one of the unintended consequences, we've become so good at distributing naloxone and saturating our community that almost a lot of people have naloxone. So if they do have a buddy or they see someone who overdoses, they administer the naloxone, they revive them, and then they don't call 911. But anyway, so once that data is pulled, once the EMS completes their chart, that data gets put into our HIPAA compliant Dropbox, and that is where our peers go in and actually try to find these individuals, and actually will go out and knock on their door and be like, hey, we saw that you had, an overdose a couple of days ago. Would you like help? Would you like assistance? Sometimes these individuals are ready to go to recovery. Oftentimes they're not. Maybe they'll take some naloxone or they'll take, a little peer card that has additional information, but they'll kind of start that process. And then, they'll follow up with them, ideally every week or two, and with the eventual goal of getting them into treatment. And then our epidemiologists, as well as our peers, all this data, as far as once the peers interact with these patients, all that data goes into the system that we use, which is called core data. And that's where we can kind of look at how many interactions we've had, how many people have gone to treatment, the different substances and drugs that are being used. Was I going to talk about this, or was this you, Brittany?
I can go over it.
Okay.
And so the reason in sharing our data flow is just so whenever we give this presentation, people kind of understand what how we get our data and what we do with it. And so we had mentioned Jacob, and through a BJA grant that we got a few years ago, we were able to hire a full-time data analysis, and we call him or a data analyst, sorry. We were able to hire him as a data improvement coordinator. And so we just wanted to improve all things data related. And we were really trying to figure out what success meant to us. Like, what is the definition of success to our QRT? And so that's kind of what led to this work that he has done. And like I said, I'm not comfortable enough with going into this, but I just wanted to share, I wanted to highlight just a couple things from it that highlights like what we've done that shows that we have been somewhat successful. And so this is what he used to um, put into the logistic regression model was this information from 2024, 2025. And so this shows like the attempted client engagements we had, the number of successful client engagements, and then what that proportion is. And it also shows like the client connections to treatment and services and what that proportion is. And so this next slide, um, so this is the outcome of the logistic regression model that he did. And like Joe said, neither of us are epidemiologists. I'm not comfortable with these things, but um, Jacob did share this that based on this simple exploratory logistic regression, we did find that the more successful interactions a client has with the QRT, there is an association with a higher likelihood of them being connected to treatment and services. So if we can connect with them, we can maintain that relationship, have multiple connections, whether that's meeting with them once to help them get insurance and ID. The next meeting is to make sure they have harm reduction supplies. The next one could just be getting them behavioral health support, whatever it might be. So essentially, the more interactions that we can have with that individual, that increases the likelihood of them being connected to an actual treatment facility or additional services. And so, like I said, if you all have any specific questions about this, feel free to let me know and I can connect you to him. But I briefly wanted to share this because I think it does highlight the success of the work that we've been doing. Um, and then this is just a snapshot of 2026 of what we've been doing so far this year. And we've received 168 EMS suspected overdoses, 4 suspected fatalities, interactions. We've had over 3,300 client interaction attempts, and then 255, those 255 unique individuals, 89 of those individuals experienced an overdose. And so, like we mentioned before, it's not just an interaction every time there's an overdose. It's you make that first interaction, and then we have multiple interactions with a client over the course of it can be weeks or it can be years. And so, like I said, this is just for 2026 so far. And then we've had over 1,800 successful interaction attempts. And that was for 186 unique individuals, and 47 of those individuals experienced an overdose. And then we've had 685 referrals to treatment and services, and then 649 connections to treatment and services. And so the difference is the referral is just us simply making the referral, and then the connection is actually connecting them to that treatment or service. And so, sorry, my I can't, Joe, can you read the top one? I can't
Yeah.
get my thing to go away at the top, so I can't see the full screen.
Yeah, so what's next? Obviously, always expanding and improving. So, the first bullet point is develop and strengthen current and new partnerships. So we're always adding new partners. I mean, if you remember that slide at the beginning that has all the logos, we're starting to run out of room because, as new partners joined, we'll add their logo to that.
And then continue to collect and analyze data for improvement. We are working to secure additional funding to keep Jacob's position and be able to have him full time. We're also in the process of implementing an overdose fatality review. And if you're not familiar with that, the goal of that is to look at fatalities and sort of identify any gaps where an individual basically looking at a decedent's life and kind of seeing like where there was a lack of a service that they needed or a gap or kind of just something that they needed that they didn't receive. And it's not to put any blame on anyone in the SUD realm. It's just to look at and see like how can we improve all work that's being done in order to prevent a fatality like this moving forward. Um, so other things, continuing to seek new funding sources. We want to continue mentoring and sharing promising practices with other overdose prevention and response programs. Further reducing stigma with community outreach efforts. I think we've done an incredible job with this over the past few years, but I think there's always more work to be done there. And then one of the areas that we are moving towards is youth prevention and understanding what our role is in that and how we can help um, agencies and organizations, specifically schools, implement youth prevention efforts. And so I cannot see the top of this one either.
Yeah, so I mean, just this was just something, explaining when we talked about youth prevention, there's primary prevention and secondary prevention. So, when we talk about youth prevention, we're really trying to enter into the primary prevention realm. So, a lot of what the QRT does could be considered, secondary, even tertiary prevention, where they're responding after the overdose in many cases, but, the goal is to really move our efforts to not only secondary prevention, but also do primary prevention as well, because we need both to be successful.
Thanks. And just expanding on the other slide about our next steps, these are just potential areas of expansion that we're looking at. That includes mental health, within that, suicide and violence prevention, as well as crisis intervention and like I mentioned, youth prevention and doing training for school resource and school security officers since they have a very large role within the school system. And within that youth prevention realm, looking at adverse childhood experiences and positive childhood experiences and seeing how we can use positive childhood experiences to mitigate the outcomes of the ACEs. And also expanding on our data analysis and implementation, this exploratory analysis that Jacob has done, we're looking at publishing that work and hopefully being able to get that out there in a journal and also sharing that at more presentation or more conferences. And then finally, the overdose fatality review that I mentioned, I think that's probably the most recent area that we've been working on. And once again, there's just an overview of all of our partners, but I think that's it. Does anyone have any questions or Joe, do you have anything to add that I missed?
Not really, just that, well, initially we started with, opioids. One of the advantages of kind of having such a large multidisciplinary group is that we're able to kind of pivot to meet, new and emerging trends. So, right now, we are seeing a decrease in opioid overdoses and actually overdoses in general. However, there are still, concerns out there, especially with different adulterants being added to substances. Some of the nitazines, the zines in general, are creating some problems as far as, longer term recovery. And we're also seeing a lot of uppers. So, whether it be cocaine, methamphetamine, or, those substances mixed with whatever other substance the person is making. So, we're constantly trying to evolve and kind of stay on top of what the new threats and issues are.